Welcome back, everybody. We appreciate that you're with us this afternoon. I am very pleased to introduce Dr. Alexis Roy. Dr. Roy is the director of director of stroke medicine at Brigham and Women's Hospital. She's an instructor of neurology at HMS, and she's also board certified in both neurology and vascular neurology. And we're very pleased to have her with us to discuss stroke in hospital medicine. Dr. Roy, thanks so much for being with us.
Good afternoon to everyone, and thank you so much for having me today. So I do not have any relevant financial disclosures to this talk. And so here are the objectives of what we'll talk about today. We'll start off by reviewing a standard workflow for a patient who develops acute neurologic deficits that are consistent with ischemic stroke. Then we'll review indications for intravenous thrombolysis, or TPA, for ischemic stroke, and we'll compare alteplase, which has been our prior standard of care for quite some time, to tenecteplase, or TNK, which many centers are switching over to, and we'll talk about the reasons for that. Then we'll review indications for mechanical thrombectomy or clot retrieval for ischemic stroke due to large vessel occlusions. And we'll go over a little bit of the history and the current expanding eligibility criteria, such that many more patients are now qualifying for this life-saving procedure. And then we'll end the talk by going over dual antiplatelet therapy, or DAPT, for TIA and minor stroke, and then briefly talk about the standard workup that all patients should get who are presenting with TIA and ischemic stroke being admitted to the hospital. So there'll be several case vignettes throughout the talk to hopefully test your knowledge. So this is the first one. And so this is a 67-year-old female who has a history of atrial fibrillation on apixaban and hypertension. And she was admitted 2 days prior to the hospital for a gastrointestinal bleed, which required her blood thinner to be held. She was last seen well by her nurse at 7 a.m. at the vital sign check. And at 9 a.m., she has a right facial droop, difficulty moving the right arm, and limited speech output. The nurse pages you to the bedside. What would be the best imaging modality to perform in this case? We can go ahead and start the poll. A CT head, B, a CT head and CTA of the head and neck, C, a brain MRI, D, a brain MRI and an MRI of the head and neck, or E, no imaging is required. Great. So it looks like the majority of you chose B, a CT head and a CTA of the head and neck, which is the right answer for most institutions. This patient's having new symptoms that could be consistent with an ischemic stroke. So a CT head would be a great first step to look for any bleed and consider their candidacy for TPA. Many stroke centers and community hospitals are also now doing CT angiographies of the head and neck to look at the vessels and any occlusions to make them a candidate for mechanical thrombectomy. If a center doesn't have angiography, A or CT head would also be a reasonable option here. MRI imaging is pretty challenging to get in the acute setting, so most times we'll prefer CT-based imaging. And I would say E is incorrect because they're having new symptoms that work out. So next, I'm going to go over a general workflow of how to think about a patient who develops symptoms that are consistent with ischemic stroke. The protocol that I'll show today, or workflow, is one that we use at my institution and is probably very similar for other places, at least in the US, but always important to familiarize yourself with your hospital's protocols because there could be some slight differences. So first, a patient develops acute, which we define usually within 24 hours, of new neurologic symptoms that are consistent with ischemic stroke. The challenging thing about ischemic stroke is that it can present very differently depending on the vascular territory that is affected. But in general, we try to think about symptoms that would localize to a vascular territory. So in the case we just presented, patients having right-sided weakness and speech output difficulties, which would very commonly localize the left MCA territory. But other symptoms to think about are usually unilateral weakness or sensory changes. Patients can have vision loss, speech changes, either dysarthria or true aphasia. And when strokes are affecting the cerebellum, they can always have coordination issues. Stroke symptoms typically develop very quickly within seconds to minutes. But in the inpatient setting, it can be really challenging to sometimes differentiate stroke from delirium and other medical conditions. So when in doubt, it's always reasonable to activate a stroke protocol, knowing that there sometimes will be false positives. So when we think a patient is having new stroke symptoms, most hospitals will have some type of stroke protocol. At academic medical centers, you may be bringing neurology to the bedside. In more community-based hospitals, patients may have, or physicians may have access to teleneurology either on the phone or via video to help guide next steps. Things we're looking for in this early setting is to get a good history that's very focused, specifically looking at what are the new neurologic deficits, when was the patient last seen well, and are they on any anticoagulants, specifically what type, and the last dose that was taken. A provider will do a focused neurologic exam called the NIH stroke scale to grade the severity of deficits. Many patients will have an IV placed and some basic labs that will be drawn, although these labs are usually not required for TPA decisions. All patients should have a finger stick for blood glucose, and then we're simultaneously trying to get the patient ready to go to the scanner. And as I said, most institutions will do a CT head and a CTA of the head and neck if it's available. We then think about when was the patient last known well or last seen normal. If the patient is within 4.5 hours, we'll consider IV thrombolysis or TPA. They have disabling neurologic deficits, which we'll talk more about. If they're not within that 4.5-hour time window, but they're within 24 hours and have evidence of a large vessel occlusion, they may be a candidate for endovascular thrombectomy or clot retrieval. Many of you may not have endovascular thrombectomy at your home center, but many institutions will partner with larger academic medical centers that I think it's important to know about this life-saving procedure because your patients may qualify. Patients who get IV thrombolysis can also still qualify for endovascular thrombectomy. And then all patients, once we're done with acute management, will get admitted for a stroke workup and initiation of secondary stroke prevention medications. Our protocols have now become very standardized with the goal of trying to be as efficient as possible to make decisions about TPA and thrombectomy, because we know that every minute lost can have reversible brain damage. So we try to work as quickly as possible to consider whether patients will qualify. So we'll move on to another case vignette. This is a 59-year-old male who has a history of hypertension, and he develops acute onset of right-sided weakness and difficulty speaking. He went to bed at 10 p.m. and awoke at 11 p.m. with these symptoms. He was brought in by the EMS. His medications include aspirin and amlodipine. Here are his vital signs when he enters the emergency department. His finger stick was 101. His stroke scale was on the moderate side of 7 for right-sided weakness, some sensory loss, aphasia, and dysarthria. He was taken for urgent imaging. His CT head didn't show any early ischemic changes, no evidence of intracranial hemorrhage, and his CT angiography showed a left middle cerebral artery occlusion. Here is his CTA showing in the red arrow the occlusion in the left MCA, and again, a coronal view of this occlusion. So what would be your next steps in management? A, admit for monitoring and stroke workup. B, offer alteplase. C, offer tenecteplase. D, offer tenecteplase and transfer to a comprehensive stroke center for consideration of thrombectomy. So it looks like the majority picked D, which I think is the most reasonable option here. As we'll talk about, both alteplase and tenecteplase would be reasonable options for TPA, but I would say D is correct because he has evidence of a large vessel occlusion and could benefit from clot retrieval or mechanical thrombectomy. So he was given tenecteplase and transferred to our academic center for consideration of mechanical thrombectomy. He went to the angio suite where we did a conventional angiogram, and this showed that actually the left middle cerebral artery had recanalized, so the blood clot was dissolved by tenecteplase, and he actually no longer required this procedure. The next day, his speech was back to normal. He didn't have any weakness and just some mild sensory loss in the right side. He actually was discharged home after 48 hours with no physical, occupational, or speech therapy needs. Here is his MRI, and the red arrow is showing a pretty small stroke considering the large area at risk with the initial clot. So a very good outcome with tenecteplase. So now we'll go and talk a little bit more about IV thrombolysis or TPA. So intravenous thrombolysis, we are referring to a tissue plasminogen activator or TPA. And this is a class of drugs that activates plasminogen to plasmin, which results in fibrin degradation, clot lysis, and ideally vessel recanalization and restoration of blood flow to the brain tissue. Alteplase has been the recombinant form of tissue-type plasminogen activator, which has been the standard of care for acute ischemic stroke in the US since it was FDA approved in 1996. Alteplase had very specific inclusion and exclusion criteria. For inclusion, patients should have disabling neurologic deficits that are expected to result in long-term disability. And their stroke symptoms should be within 4.5 hours of last seen well, and their age should be greater than or equal to 18 years old, although we will sometimes extend it to younger patients in select situations. We have several exclusion criteria. Probably the most important is a CT head that shows evidence of intracranial hemorrhage. If their clinical presentation is suggests a subarachnoid hemorrhage, if they've had head trauma, a recent stroke, or intracranial or interspinal surgery in the past 3 months, we usually exclude them. If their blood pressure is elevated, greater than 185 over 110, despite antihypertensive medications, we cannot give TPA. If they have an active bleeding diathesis or recent anticoagulant use, they'll be excluded. For our recent anticoagulant use, we define it as a DOAC within the past 48 hours. Warfarin if you have an INR greater than 1.7, or heparin use with an elevated PTT. The exclusion criteria can vary a little bit from institution to institution, so it's always good to familiarize yourself with your hospital's protocol. So tenecteplase, commonly referred to as TNK, is a newer agent that many centers are switching over to, and your center may have made the switch already. This is a modified version of alteplase that has amino acid substitutions at 3 sites that offers several advantages over alteplase. Here's a table that compares the 2 types of TPA, alteplase and tenecteplase. So one of the main differences is that alteplase has a much shorter half-life. This means that it's given at a dose of 0.9 mg per kg. 10% of this is given as a bolus, and then the remaining 90% needs to be infused over the next hour. In comparison, tenecteplase is given at 0.25 mg per kg, and it's given as a single bolus without the need for an infusion. There's also differences in some of the factors listed, including that tenecteplase has 15 times higher fibrin specificity than alteplase, increased resistance against plasminogen activator inhibitor 1 activity. With respect to systemic coagulopathy, alteplase does have fibrinogen depletion, which can increase the risk of hemorrhage and the most feared complication of intracranial hemorrhage. Tenecteplase in vivo hasn't shown coagulopathy markers to be affected, but as I'll show in subsequent slides how this plays out with respect to bleeding risk in real patients. And then importantly, with respect to drug costs, tenecteplase is currently significantly cheaper. So there have now been many trials comparing alteplase versus tenecteplase. I'm going to just give you a very high-level view of some of the trials over the past 10 years, not expecting you to remember the names, but just the high-level points. So one of our first big trials in 2015 looked at tenecteplase versus alteplase in patients coming in with ischemic stroke within 4.5 hours, and found tenecteplase to be as safe and effective as alteplase with no difference in symptomatic intracranial hemorrhage. Extend IATNK in 2018, again looked at patients coming in with ischemic stroke, but also had evidence of a large vessel occlusion, and actually found TNK to be superior for recannulizing the large vessel occlusion, which led to better 90-day functional outcomes, and again, no difference in bleeding, as we saw in the second case vignette. TASTE A looked at tenecteplase in mobile stroke units, and again found it was superior in this very early reperfusion compared to alteplase. And then more recently, we've had 2 large trials that found TNK to be as safe and as effective as alteplase, with non-inferiority being met. It is important to note that we've had different dosing of TNK, the 0.25 mg per kg and the 0.4 mg per kg. We have found this higher dosing to actually increase the risk of bleeding without better outcomes. So therefore, the current standard of care is the lower dosing of 0.25. So now some real world practice, because many centers have switched over. As I said, some studies have found higher rates of intracranial hemorrhage, but this is really being driven by the higher dosing of TNK. When we actually look at the lower dosing at 0.25, we've actually found similar or even lower rates of symptomatic intracranial hemorrhage, similar functional outcomes, and then importantly, faster door to needle times, so time from the patient entering until when they get infused with the drug, and faster transfer to stroke center times. And we think these improved times are being driven by the need for only a single bolus without an infusion, which leads to easier preparation, the lack of a need for a continuous infusion pump, and not the needing higher level of ambulance care. And overall, there's been improved nursing satisfaction as well with this easier administration of the drug. It's also been shown to have decreased healthcare cost, given its currently cheaper price. And because of all these benefits, many stroke centers have made the switch to from alteplase to tenecteplase as the IV thrombolysis of choice. Some important regulatory considerations are, though, that the FDA has currently only approved TNK for acute myocardial infarction. It's actually not approved for acute ischemic stroke at this time. That being said, there is precedent in that alteplase, our previously used drug for TPA, is only FDA approved for 3 hours from last seen well, but we widely use it up to the 4.5-hour time mark based on prior studies. The 2019 American Heart Association practice guidelines, which are somewhat outdated now, say that TNK can be considered in large vessel occlusions less than 4.5 hours from last seen well who are going to undergo thrombectomy, or patients with minor neurologic impairments who do not have a large vessel occlusion. Although the indications are somewhat limited, and by the AHA guidelines, most centers have switched from alteplase to tenecteplase use the same inclusion and exclusion criteria that I showed on the prior slide that we had previously used for alteplase. So here is the next case vignette. This is a 52-year-old right-handed man who comes in with right-sided weakness and difficulty speaking. He was last seen well 5 hours prior to presentation. He was found in bed by his wife. He has no known past medical history and was not taking any medications. He was brought by ambulance to our emergency department. His vital signs are shown here. His stroke scale is quite high at 16 due to difficulty answering orientation questions, inability to follow commands, a gaze palsy, weakness on the right side, aphasia, and visual field deficit. His finger stick for blood glucose was unremarkable. His CT head showed a large established infarct already on presentation, and his CTA showed a proximal left middle cerebral artery occlusion. What would be your next steps in management? A, admit to the neurology ICU for close monitoring. He's high risk for cerebral edema, need for hemicranie. B, offer tenecteplase, C, mechanical thrombectomy, or D, goals of care discussion and consideration of comfort measures. So what I'll next go over is that we've now had 6 large randomized control trials that have actually shown the benefit of mechanical thrombectomy for patients with large infarcts on presentation. Prior to even 2 years ago, A probably would have been the right answer. This patient is at risk for a very large stroke with cerebral edema that can lead to herniation and many times will need the skull removed. He's not a candidate for tenecteplase, as shown in B, because he's outside the 4.5-hour time window. And D can be considered, but given his young age and lack of prior disability, most people would probably continue to provide aggressive care. So to continue the case, he didn't get T and K for the reasons that we talked about. Given his young age, he was taken for mechanical thrombectomy and had recannulation of the middle cerebral artery. He still suffered a large infarct, required a tracheostomy and PEG, and was discharged to rehab. When I saw him 1 year out from the stroke, he had a mild non-fluent aphasia, a right field cut, right drooping of the face. He was plegic in the right upper extremity, but only had very mild weakness in the right lower extremity and was actually able to ambulate with the cane independently. His PEG and trach were out. He was eating normally by mouth. He was independent in all of his ADLs and required help with just some of his IADLs. This is his head CT, and you can see on the left MCA territory, he suffered a very large infarct. And I wanted to introduce the concept of the modified Rankin scale, or MRS, which is the main outcome measure we use after stroke. This ranges from 0 to 6, where 0 is no symptoms and 6 is death. And then we have gradation based on the ability of the patient to ambulate and need for assistance. So this patient had an MRS of 3 with moderate disability. He did require some help, but could walk without assistance. So considering the size of his stroke, we would consider this to be a very, very good outcome. So now we'll move on to talking about endovascular thrombectomy or clot retrieval. And we'll go a little bit over the history because this field has really evolved over the past decade, and then talk about the expanding eligibility criteria. So we'll specifically focus on large vessel occlusions in the anterior circulation. So what is an LVO? Traditionally, we refer to this as an occlusion in the intracranial internal carotid artery and or the proximal middle cerebral artery. So if you remember your circle of Willis from medical school, we're really talking about clots in this distal ICA, and as it branches into the MCA and ACA, this very proximal MCA region. So what is mechanical thrombectomy? This is an endovascular procedure where we will obtain arterial access, usually through ephemeral artery groin puncture. Thus, commonly, we can also do a radial artery puncture, and we'll thread the catheter up to the intracranial circulation. And if you look at B, we'll inject dye, and this is showing the ICA branching into the ACA and MCA. And right here where this white arrow is showing a clot in the middle cerebral artery. Once we've identified the clot, there are various techniques we can use to try to remove it. Most commonly, here we'll use a stent retriever where we'll deploy a stent around the blood clot and then pull out the stent with the clot. Another option is an aspiration device where we hook this straw kind of up to vacuum and then we'll suck out the clot. All the way at the end of B is now showing we've removed the clot and there's good flow in the distal MCA territory. So in the early 2010s, there were 3 randomized controlled trials that actually failed to show any benefit of mechanical thrombectomy in patients who had stroke and large vessel occlusions. We think these negative trials were driven by poor patient selection and endovascular techniques that were still really in their infancy with a lot of morbidity associated with them. 2015 was a really exciting time where we had 5 randomized controlled trials that actually showed the benefit of mechanical thrombectomy in patients who had large vessel occlusions presenting within an early window, which we say within 6 hours of lasting well, and had a small stroke on presentation. Then in 2018, we tried to extend the window beyond 6 hours by using advanced imaging, either MRI or CT perfusion. And we were trying to select patients who had small strokes on presentation, but large penumbras or area at risk. And by doing this, we could extend the window from 6 to 24 hours. And these patients showed a benefit of mechanical thrombectomy. For those who are not familiar with CT perfusion, this is a summary printout that we'll get. And here on the left is showing the established stroke or core in pink. And we're looking for this to be small. And then on the right is the penumbra or area at risk in green. And we're looking for this to be large. So a big mismatch between the established stroke and the area that could be salvaged if we were to restore blood flow by removing the clot. So our current indications for endovascular thrombectomy are shown here. Patients should have moderate to severe stroke, defined as a stroke scale greater than 6, a proximal large vessel occlusion in the ICA and or MCA, and a small stroke on presentation. If they're within 6 hours from last seen well, consideration of advanced imaging to show the small stroke but the large penumbra. However, there's been increasing concern in the stroke community that we've been too selective and the patients were offering this life-saving procedure. And now there's increasing interest in trying to expand who may benefit from this procedure. So this brings us to the third case vignette, a patient coming in with a really large stroke on presentation. And I just wanted to introduce the term aspects, as you may hear your stroke team talk about this. Aspects is a system to grade the size of a stroke on a head CT. And in the very basic sense, we give 10 points to regions in the middle cerebral artery territory, and we subtract 1 point for every area that's showing ischemia. So if you have 10 points, that means there's no evidence of stroke yet. And if you have 0 points, it means that you've stroked out the entire MCA region. We say anything 6 or greater is a mild to moderate stroke, and that's what we included in those 2015 trials. But then in the past 2 years or so, we've had 6 randomized controlled trials that have included patients with very large strokes on presentations, aspects as low as 5 or as low as 0 up to 5. And when we look at these meta-analyses of these 6 trials for patients coming in with large strokes at presentation, when we compare endovascular therapy to medical management, we consider a good outcome to be anything on the MRS scale of 0 to 3, and we see many more patients achieve that with endovascular therapy than they do with medical management. To put some numbers to this, number needed to treat for a better functional status with mechanical thrombectomy is 4.7. To achieve independent walking is 7.1 number needed to treat. One of the feared complications was increased risk of bleeding. If we were to remove the blood clot and the patient already has a large stroke, when you restore blood flow, there could be bleeding into the stroke bed. However, our safety analyses actually didn't show any increased risk of symptomatic intracranial hemorrhage with mechanical thrombectomy compared to medical management. So I do want to make the point that now in select patients, we've shown significant benefit for mechanical thrombectomy who have large strokes on presentation. However, patients coming in with large strokes still have worse outcomes with mechanical thrombectomy compared to those who have small strokes on presentation. So here again is that MRS scale, and patients who have small strokes from our 2015 trials, 27% are going to achieve a very good outcome of 0 to 1 versus only 8% of our large cores. And there's double the mortality rate in patients coming in with large strokes on presentation. All to say that this procedure can still be beneficial for large strokes, but they can have a worse outcome than those coming in with small strokes. So one of their questions is, why are patients doing better with mechanical thrombectomy if they've already have a large stroke on presentation? Interestingly, there's no difference in the final infarct volume between those who got medical management and those who got mechanical thrombectomy in these large core trials that I showed. We think potentially removing the blood clot may lead to a reduction in edema, and this decrease in edema may be improving outcomes. Another thought is that the core is not fully dead, and although it looks like the patient may have infarcted the whole territory on our head imaging, there actually may be islands of preserved tissue that we see on histology with mechanical thrombectomy, and that could be driving the improved outcomes. So to think about how we can further expand the boundary of this life-saving procedure, we're still continuing to refine what patient populations with large core are going to benefit from this procedure. And we didn't talk about this, but there have been more recent trials as well showing that basilar artery occlusions are in the posterior circulation can also now benefit from mechanical thrombectomy. There's work looking at medium vessel occlusions or more distal MCA vessels and seeing whether these patients would also benefit. This brings challenges of trying to identify these smaller blood clots on CTA and trying to improve our catheter techniques to reach the clots. And then many patients with baseline disability have been excluded from trials and excluded from current therapy. So looking into including patients with baseline disability and how they may also benefit from this life-saving procedure. And then, of course, combining mechanical thrombectomy with other therapies, or what we call neuroprotectants, so medications that we can infuse or inhale that can help preserve the ischemic tissue, either while we're awaiting for mechanical thrombectomy or after mechanical thrombectomy has occurred. So now we'll move on to the last part of the talk. We'll specifically go over DAPT and secondary stroke workup. So for short-term DAPT or dual antiplatelet therapy for high-risk TIA or minor stroke, we use this to really reduce the short-term stroke risk. So I wanted to define what transient ischemic attack or TIA is, because this definition is constantly evolving. So a TIA is a brief episode of neurological dysfunction caused by either focal brain or retinal ischemia. Symptoms typically last less than 1 hour, and there's no evidence of acute infarct on imaging. And specifically, we're talking about MRI. Prior to MRI, it's very hard to see small strokes on CAT scans. So with advancements in our MRI, many things that we may have previously called TIAs were actually minor strokes that we just couldn't see on CAT scans. TIAs have a high risk of stroke, anywhere from 4 to 10% within the first 48 hours. Given this really high risk of stroke after TIA, there's been a lot of efforts to try to reduce the recurrence of an ischemic event, and most of our benefit has been seen with DAPT to reduce this risk. So here's a flow chart from the American Heart Association 2021 secondary stroke prevention to kind of think about how we can use DAPT in this patient population. So if a patient has a non-cardioembolic TIA or minor stroke, we'll divide it into stroke versus TIA. So if they have a TIA, we'll think about whether it is high or low risk. If it's low risk, we'll usually give a single antiplatelet, either aspirin or clopidogrel. If it's high risk, that's when we think about using dual antiplatelet therapy. Most of our clinical trials have used a loading dose of clopidogrel, less commonly ticagrelor, plus aspirin, and we'll do this for 3 to 4 weeks. We find that 3 to 4 weeks is where you get the most benefit of stroke protection with the lowest risk of bleeding. And after that 4 weeks, the bleeding risks outweigh the stroke protection. So after that point, we'll de-escalate to a mono antiplatelet, usually either aspirin or clopidogrel. Ideally, we're giving DAPT very quickly within the first 24 hours, and that's really when we've seen the most benefit. So how do we define what is a high-risk TIA? We have something called an ABCD2 score or calculator that you can get on MedCalc online. And this is a calculator that's actually designed for non-neurologists to grade the risk of recurrent stroke after TIA. And it gives various points for things like age greater than 60, if you come in with elevated blood pressure greater than 140/90, the clinical features of the TIA. If you have unilateral weakness or speech disturbances, you'll get higher points. The duration of your symptoms, the longer your symptoms, the more points you get, and whether you have a history of diabetes. Based on the points you get, anywhere from 0 to 7, we can grade your 2-day risk of stroke. We consider any score 4 or greater to be high risk, meaning that you carry greater than a 4% risk of recurrent stroke. And these are the patients we're really concerned about and the ones we gear our DAP towards. Next, to think about minor stroke, the other half of the pathway. We think about ischemic stroke, whether it's early, which we typically mean within the first 24 hours, although we can sometimes extend it out to 7 days. We want the stroke to be minor, so an NIH stroke scale of less than or equal to 3. And then if you are on this side of the pathway, again, we think about using dual antiplatelet therapy. Again, similarly, loading dose of clopidogrel, less commonly ticagrelor, plus aspirin that we'll use anywhere from 3 to 4 weeks before we de-escalate to a mono antiplatelet therapy. So here is another and final case vignette. This is a 68-year-old male who has many vascular risk factors, hypertension, diabetes, hyperlipidemia, who's coming to the emergency department for a 5-minute episode of right-sided weakness and slurred speech that happened about 2 hours prior to presentation. On examination, he's back to baseline. His blood pressure is 180/100. His ABCD2 score is 4, so he's considered high-risk TIA. A CT scan of the head shows no acute hemorrhage. What is the most appropriate next step in management to help prevent future strokes? A, initiation of dual antiplatelet therapy with aspirin and clopidogrel. B, initiation of dual antiplatelet therapy with clopidogrel and ticagrelor. C, just mono antiplatelet therapy with aspirin. Or D, initiation of anticoagulation therapy while awaiting the results of his cardiac monitor. Great. Seems like everyone voted for A, which is what I would say is the correct answer. This patient has a high-risk TIA for which there's really good evidence for DAPT, either with aspirin and clopidogrel or with aspirin and ticagrelor. B, I would say, is incorrect. We don't use clopidogrel with ticagrelor. It's either one or the other with aspirin. I would say C is incorrect in that he is a high-risk TIA, and we really want to use DAPT and not mono antiplatelet therapy in this setting. And then D, we typically don't initiate anticoagulation therapy unless we have a clear indication like atrial fibrillation. Great, so now we will end the talk by going over the American Heart Association standard ischemic stroke evaluation. So this is what all patients should get who are being admitted for a workup of TIA or ischemic stroke. So we typically will get some brain parenchymal imaging to both confirm the stroke and rule out stroke mimics. Many times the emergency department will be getting a CT of the head, which is very good for ruling out bleeds, but brain MRI is much more sensitive to pick up small strokes and rule out stroke mimics. Patients should get some type of arterial vessel imaging of the head and neck. Both CTA and MRI are great modalities, but carotid ultrasound can also be considered. It's important to note, though, that carotid ultrasound really only gives us views of the carotid bifurcation and doesn't give us a lot of information about what's going on intracranially, in which there could be pathology, and gives us very limited views of the posterior circulation. For that reason, it tends to not be the preferred imaging modality. All patients should get a transthoracic echocardiogram, or TTE, to look for any cardioembolic sources like new reduced ejection fraction or left ventricular thrombus. In patients who were less than 60 years old who have minimal vascular risk factors, I'll also consider doing a bubble study to look for a patent foramen ovale, or PFO, which could be the cause of embolic stroke. At the very least, all patients should get an EKG to look for any arrhythmia. Specifically, we're looking for atrial fibrillation, which would necessitate a change from an antiplatelet to an anticoagulant. Patients who are getting admitted most commonly will be placed on telemetry to continue to look for any arrhythmias. And any patient in which the cause is unknown on discharge should get an external cardiac monitor to look for atrial fibrillation. The American Heart Association guideline doesn't give us specific recommendations on the exact length of cardiac monitoring, but most providers will do anywhere from 14 to 30 days of additional monitoring on discharge to look for atrial fibrillation. We recommend, at the very least, some basic serum labs, a CBC, troponin, coags with the PT and PTT, and hemoglobin A1C, and lipid profile for risk stratification, and to allow us to initiate secondary stroke medication, such as a statin. And then with respect to timing, ideally all of this testing is performed within 48 hours of symptom onset, because as we talked about, especially patients in TIA who are presenting with TIAs have a high rate of subsequent stroke in the next few days. So we like to do this workup to try to figure out the cause and initiate secondary stroke prevention medications as soon as possible. So here are the key take-home points for today's talk. In the beginning, we talked about a workflow for patients who are developing acute ischemic stroke and talked about how to think about using TPA and mechanical thrombectomy. It's important to familiarize yourself with your hospital's acute stroke protocols because they may differ from institution to institution. We talked about how tenecteplase at the 0.25 mg per kg dose is not inferior to alteplase for acute ischemic stroke. Many centers are switching to tenecteplase for all its potential benefits, including lower cost, ease of administration, given that we do not need a continuous infusion, and as we showed in our case, improved recannulization of large vessel occlusions. We talked about the use of mechanical thrombectomy in patients who have evidence of blood clots in either the intracranial internal cerebral artery and the middle cerebral artery. Traditionally, mechanical thrombectomy has really been reserved for a small subset of patients with small strokes on presentation, but we're now expanding our boundaries of who may qualify. And specifically, we talked about 6 recent trials that show the benefit for patients with large strokes on presentation. And then we ended the talk by going over how DAPT, or dual antiplatelet therapy with aspirin and clopidogrel, or aspirin and ticagrelor, should strongly be considered in anyone presenting with a high-risk TIA or a minor stroke. And then all patients admitted for TIA and stroke should undergo a standard workup to try to determine the cause of stroke and initiate the appropriate secondary stroke prevention medications. And that is the end of the talk. I think we have about 5 minutes or so for some questions. Thank you so much.
Hi, Dr. Roy, can you hear me?
Yes.
So I want to thank you so much for doing that talk. So Dr. Roy had big shoes to fill. Unfortunately, in the past year, we lost Dr. Galen Henderson, who was a longtime friend of the course, who did this talk. He's one of many colleagues, unfortunately, who passed too soon in the pandemic years and after. So he's dearly missed by friends, family, and colleagues, and we thank Dr. Roy for stepping in so ably. So we have a number of questions from our fantastic, very thoughtful audience. So a number of questions about tenecteplase. One comment that someone from hospital that switched to tenecteplase, had a number of patients with intracranial hemorrhage, and then stopped using tenecteplase. So maybe you could comment about that and risk factors perhaps for intracranial hemorrhage that are not necessarily, you did not necessarily discuss in the context of exclusion criteria for using tenecteplase and TPA.
Sure. It's a great question, and it's important, as I had first mentioned, to think about what dosing of the tenecteplase was being used, because the higher dosing has been shown to have increased rates of intracranial hemorrhage. And at our stroke conference a couple of years ago, there was some experience of concern for increased hemorrhage. But we're not sure if some of that in the early centers was being driven by just inexperience with the drug and how it was being prepared and the dosing that was being administered. But our larger randomized control trials and real world evidence has not suggested that the lower dose does lead to increased risk of hemorrhage. And if anything, actually leads to lower rates of symptomatic intracranial hemorrhage. The times we really worry about hemorrhage in patients who were giving TPA, either alteplase or tenecteplase, are usually patients who are coming in with large strokes on presentation. So greater than 1/3 of the MCA territory is a very high risk for intracranial hemorrhage. And then patients with underlying conditions, for example, cerebral amyloid angiopathy or CAA, which may be undiagnosed, carries a much higher risk of intracranial hemorrhage with any TPA. And then, of course, if there's other tumors or something else, vascular malformations that we're unaware of, that can also increase the risk of intracranial hemorrhage.
Excellent. Could you talk about management of ischemic stroke in the context of patients who are admitted to the hospital and say undergo a stroke in the setting of after an orthopedic surgery or after cardiac catheterization?
Sure. So if it's a clear provoking factor, like a procedure in the heart, like a valve replacement or cardiac catheterization, where something can be flicked into the intracranial circulation, we still probably will do kind of the full stroke workup we talked about, even though we do know what probably caused the stroke, just to make sure we're not missing anything else. And then most of the time, if they don't have evidence of atrial fibrillation, we'll probably use a single antiplatelet therapy, unless it was very, very clearly provoked by a valve replacement and there's no indication for ongoing antiplatelet therapy.
Excellent. And could you comment on differentiating a TIA from non-specific complaints such as focal paresthesias? So sort of borderline cases for TIAs.
Yeah, this is a question we get a lot on talks like this, and it is really, really challenging, especially for the frontline ED and hospitalists who maybe are not stroke or neurology trained. So we really try to look for things that time course makes sense and territory makes sense, like acute onset of weakness or paresthesias of the face, arm, and leg are much more classic for a TIA. Patients who have migrating paresthesias that are in the arm that come and go are less likely to be TIAs. But I know in the emergency room setting, it can be really, really challenging to differentiate a TIA from a migraine from maybe some other stroke mimic, and is almost a whole talk in itself. But I think it's never wrong if there's some suspicion for TIA to do the appropriate workup, to start the secondary stroke prevention medications. And if in follow-up with neurology, it seems less likely to be a TIA, we can always de-escalate the management.
Awesome. Thank you so much for a great talk and a great question and answer session.
Yeah, thank you so much for having me. I appreciate everyone's participation.